It's always a pleasure to come here and present some of the already things that you're already doing here in Cairo and in Egypt. I will just follow on what has been the main theme of this session, which is radiofrequency. We've seen Dr. Shadi and Dr. Ahmed Bissar and Ahmed Nagar talking about radiofrequency ablation. So we'll try within this next 15 minutes dive more in the basics of radiofrequency ablation and what it means and what can achieve. So this is the theme or the outline of my presentation. We'll talk about the basics of radiofrequency ablation, types and techniques, and some application. We'll focus in my presentation, we'll focus on presentation on the nerve applications. Okay, sorry, there's something. Okay, so radiofrequency ablation is not a new technique. It's been there for the last more than 25 years. It's ironically, it was done by the neurosurgeon. So this is one of probably the few things that we got from the physician. Most of the time it's the other way around. The physician and surgeon take from our techniques. It is based on interruption of the pain signal, what we call the nociceptive input. But the added advantage of radiofrequency is not just the production of heat, it's also the electric field that is produced around the electrode. So we have two advantages. There's two things that are happening at the same time, is the production of heat and obviously the production of the electric fields. So we can use it in any pain syndrome in our body, either the spine or peripheral nerves. It's very, very important to understand that radiofrequency ablation is not electrocautery. So the source of the heat is not the electrode itself. The source of the heat is the tissue around the electrode. And it's very, very important. This makes it more safer than other techniques. So what happens when you put the electrode, the nearby or adjacent nerves or the adjacent soft tissue, the electron will start to oscillate and produce this heat. And as you can see from the graph on the right side, the heat drops significantly as we move away from the tip of the electrode. So you have to be as close as possible. The target has to be as close as possible to the electrode. So this is a typical setup of the radiofrequency ablation. We have a generator that produces in average 500 kilohertz. We have an electrode which is Teflon coated, but the tip, which we call it the active tip, is made of a metal. We place the electrode in the body. We have to put a pad, what we call the earth pad, as you can see here in the diagram. And the earth pad should be placed as close as possible to the electrode, because you don't want to subject an area more than needed for this electric current. Then we start to stimulate the area, especially when we're doing nerve, because we want to confirm the size or the site of the needle by doing this what we call electrostimulation to produce the exact pain, so we know that we are an exact site. Then we start doing the ablation. And as I mentioned, when you do the ablation, there is two possibilities there. There is production of heat and production of electric current. There is two options. So once the needle is inside, you have two options in the same machine. All the machine comes with two options, either doing continuous, what we call lesioning, radiofrequency ablation, or pulsed. And you can see from the diagram, from its name, continuous, it's just continuous RF, which can raise the temperature up to 90 degrees. And at 90 degrees, as you can see in the diagram, at 90 degrees, there is instant cell death. Okay, so an instant, with less than 1 second, the nearby cell will die. But with the pulse, all you're relying in is only the electric field. And the maximum temperature that we can use is 42 degrees. And we can use this pulse when you are worried, because if we are close to a motor nerve, of course, the last thing we want to do is cause damage to this motor nerve. So our option will do radiofrequency ablation pulsed. Why pulsed radiofrequency ablation works? Basically, we don't know. Why, when we subject tissue or nerves indeed to electric field, why it stops pain, we don't really know. However, in some vitro studies, they say when a tissue is subjected to radiofrequency or electric field, there is reduction in what they call the interleukin or the pro-inflammatory cytokines. And you can see the interleukin 1B and the necrosis factor, and indeed the prostaglandin type 2, which is the main factor in producing of inflammation, gets reduced. For some reason, we don't really fully understand now why this happened. However, we don't really need to care because it's safe and it's effective in most patients. And you can see from the studies that there is no what we call controlled studies that you can say the efficacy of one to another. However, it's been known and is agreed, so if you use radiofrequency continuous, it produces longer period of pain relief. You can see at 6 months and a year, there is more reduction. However, the pulsed is safe. Actually, there is no known side effects of pulsed radiofrequency ablation. The only thing that you need to be aware with, of course, is continuous, is it kills the nerve. So if it is motor, so you can induce, of course, muscle paralysis or muscle damage. And also it comes with something called rare side effects called differentiation pain. So when there is a sudden damage to the nerve, it can cause hypersensitivity. Okay, and one of the most popular type of differentiation pain we come across is patients when they have amputation, they have this kind of what we call ghost pain or neurogenic pain. So it is something you need to be aware of, that sometimes it can cause extreme pain. So the tip of the needle, as you can see, is the active tip. The most important part is the shaft of the tip. As you can see here from the diagram, the tip of the tip, there is nothing there. So if you want to achieve a good ablation, your tip of the needle should be parallel to the nerve, not perpendicular, because the parallel is where the radiofrequency is. And RF ablation, what we call the dose, remains not standardized for how long we need to apply the ablation. Sorry, I'll go back. What makes things more complicated, if you work in a place and they have the ability to procure or get you whatever you want, what type of needle, so you will notice that you have different types of needles available in the industry. There is monopolar, and you can see there is straight, there is curved, there is blunt, there is one what we call the extended radiofrequency. Depending on the manufacturer, they can call it Venom or Sidekick. If you're using Stryker, they use it Venom. If you're using the Boston Scientific, they do it the Sidekick. And you can see the cooled one, which is there is saline that is circulated at the tip, so to increase the heat and the size of the fin. And there is the wet, and there's the bipolar. So you can see there is a lot of variety of needles that you can use. And the whole idea of this different needle is to increase the size of the ablation area. Because it's sometimes in most of the patients, it's very difficult to put the needle exactly in the right place. And this is explained sometimes why RF ablation doesn't work, because you're not really in the right place. So the way around it is to cause, to increase the area of the lesion. And the bipolar, as you mentioned in a couple of the presentation, is becoming more and more popular. And you have two options with the bipolar, either to just putting two needles, or recently they produce one needle that they use in the disc now that contains the bipolar. But the bipolar, one single needle bipolar, is not something available in Europe. And indeed, where I practice in UK, it is only available in the United States. So it's not something that we have. And the whole idea is, again, to expand the area, the effect area. And you can have mix of match of them. So in Oxford, where I practice, this is our routine. This is what we agreed routine dose or RF dose, depending on whether we're going to do RF pulsed or lesional. We do 42 degrees or 90 degrees, but don't do more than 90 degrees, please, because above 100 degrees, this is where the tissue will boil, and when the tissue will boil, it will produce gas, and gas limits the size. Okay, so the maximum you can get is 90 degrees. Put it for 33 minutes. The tip of the needle, you have the option of 5, 10, or 15. It really depends on the size. If you are doing metastasis, for example, you want to go for the 15, the maximum you can get. If you use a small nerve, you can use 5. If it is a medium-sized nerve or medium-sized needle, you can use 10. And again, it comes with distance and diameters. And why this is important? Because this is how the distribution of heat is. So if your target area or nerve is away in the 40 degrees, so you're causing less damage to the nerve. And this is graph, I mean, this is just not to get, confused, but the whole idea of this graph is that people don't, or the radiologist or physician that use ablation, they have the option. They don't know whether to put the ablation for 1 minute, 2 minutes, 3 minutes, 6 minutes, or 10 minutes. There is no agreed time for that. However, this is just to show you that time is not always the best thing. It's the size of the needle. So you can see if you put at 3 minutes, the size of the lesion is 8 millimeter. And when you go for 6 minutes or indeed 10 minutes, it only increases the area by 1 millimeter. So it doesn't worth it because you can see the plateau, the heat start to plateau. So it's better if you want to produce more damage, you have two options. Is to increase the size of the needle rather than doing more. So you go for 16 gauge. Or indeed, you can go for bipolar, okay? So that's why it's important I personally think is increasing the size of using bipolar is better than doing, putting the patient for 6 or 12 minutes. And this is the reason, this is the physics behind it. So we now know the basics. So now we'll just go through some applications, which was already nicely done by my colleague in the beginning of this session. So you can see there is a long list of radiofrequency ablation. It's becoming very, very popular, by the way, and especially during the COVID-19 and pandemic. In UK, there was restriction of injecting of steroids because they were worried that steroid will reduce the immunity and increase the patient of the virus. That's why all of the hospitals and centers like ourselves start to using radiofrequency ablation rather than injection steroids. And since then, things become more and more effective and be used more. So we already, Dr. Tarek mentioned the suprascapular nerve block. So we use the same. We use the suprascapular nerve. It's as you can see, is a branch of the brachial plexus. And the nerve, the shoulder nerve, is supplied by the suprascapular nerve is in 80% of the sensation, but 20% is supplied by axillary. So when you achieve the maximum you can achieve, or those pain is 80% reduction of pain. So it is we go from the supraspinatus approach, and the whole reason why we do that, because we want to be parallel to the nerve, because this is the whole idea why we come from the top, because if you come directly, you might miss the nerve. And you have two options. You can go further distal, where the sensory nerve, what you call the nerve going to the shoulder, and you can apply, in this instance, when you can reach this position, you can apply continuous radiofrequency, because this is only sensory. But for any reason, you couldn't do that because of the severe osteoarthritis, or you don't have the skills or the way to do it. All you can do is just do it in the suprascapular fossa, and you do pulsed, because pulsed is safer, and you don't want to cause injury to the motor supply of the nerve, which is especially the supraspinatus and infraspinatus muscles. And we published our work in 2021 by using this lesional, because the practice before that was just pulsed. So we changed our practice in Oxford, and now we do continuous for every patient, because we are getting better in knowledge of doing that and more in distal. So we can do direct or lesioning continuous radiofrequency ablation. One of the other things used is the stum neuroma. So it's painful neuroma for those patients, so and patient with amputation. And currently we're working with the Army, because of course in the Army there is a British Army, there is kind of more population of amputees, and it's very painful, so we do the same thing. And with a bigger, so before, as mentioned, 3 centimeter was our cutoff, but now because we can use multiple or bipolar or even tripolar, size doesn't matter anymore. And you can see in this patient, they have a lesion more than 4 centimeter, and you can see that we put the electrode here and we put 2 electrodes there, and the patient didn't feel any pain after that. And again, we publish our work, and most of those patients, they really do very well with stum neuroma pain. Other neural pain, like this patient, had multiple neurofibromatosis, and you can see there is a small neurofibroma deep to the scapula that the plastic surgeon couldn't get into it surgically. So, and we've done by ablation. I think my colleague mentioned genicular nerve ablation, which is something we do, and he eloquently mentioned that and described it. I wouldn't go through that, but the whole idea is to ablate the superior medial and lateral and the inferior medial in those patients. The main tip, if I have to give you, is just when you do the ablation, try to be tangential to the femur, because as I mentioned, you want to be in contact with the nerve. Something that we start doing for those patients is the obturator nerve for patients with hip pain, with severe osteoarthritis, or pain after total hip replacement. You can ablate the anterior branch of the obturator nerve, which supplies the hip. And you can see this patient, we've done a monopolar for this patient, and it done very well. You can do it under ultrasound if you can have the skill to ablate the anterior obturator nerve. Or also you can use the bipolar approach. And my advice is, if you're going to use a bipolar approach for one single lesion, the tip of the needle should be always within 1 centimeter. Don't do more than 1 centimeter, because in this instance, the tip, the two electrodes act as one electrode. And the reason why this patient, we do bipolar, because as you can see, this patient have a spinal stimulator. And one of the contraindication of unipolar is when some patients have cochlear implant or pacemaker or spinal stimulator, because there is some reports that ablation, radiofrequency ablation, can cause malfunction. So if you want to avoid that, you need to do the bipolar technique to avoid that. One of the things we started doing also for RF ablation is patients with hemiplegia. They can suffer from what we call spastic hemiplegia. So one of the ways is to ablate the nerve. And this patient comes with this kind of flexion deformity, severe flexion deformity. What they do, the neurorehabilitation, they inject the muscle with Botox. One of the other possibility is to just ablate the nerve. And this is a case that we've done. The patient would have flexion, and we wanted to ablate the musculocutaneous nerve. And you can see here, this is the musculocutaneous nerve between the medial and the both heads of the biceps tendon. Then you can see the needle coming there, and you can see on the right side of things, we stimulate the nerve to know that we are in the right place. And you can see the biceps muscle is pulsating, so we know that we are in the right place. And instantly, when we apply the ablation, the patient spastic hemiplegia is treated instantly because we ablated the nerve. And this is just a summary of my radiofrequency ablation. It works, and it can be used in not just in the spine. We can use in the peripheral nerve. I can just leave you with one of the feedback I got one of the patients a couple of weeks ago about how technology can help patients and can help our patient. Thank you very much.